Okay, we are going to talk about the case investigation. Okay, before we go in, what do you know about case investigation as a RRT team? What do you know about case investigation? Some brainstorming? They're not talking.
Can you unmute? Can you unmute? Are they frozen? Oh, they ran out of credit. Oh no, he's okay. We just have to tell him to unmute.
Unmute, Gibson.
Hello,
Hello.
can you hear me?
Yes.
Okay, there's some response coming from Oro. Tomorrow.
Case investigation simply is, I think, trying to establish the cause of the disaster or the problem that is going on within the community.
Okay, thank you. But here we are focusing on COVID-19. So usually when we say for case investigation, we are looking at the positive cases of COVID-19. When we receive the positive case, then how do we initiate the case investigation? Okay, we'll talk more about that. Okay, after this session on the case investigation, at least you should be able to distinguish between a patient symptom onset, date of onset, symptom onset date, the incubation period, and the infectious period. The timing is very, very important as a RRT team or the case investigator. And the second objective, you have to describe the principles of case investigation, including the interview elements, which you went through with Tambri. At least use some of those basic principles to guide you during the interview. To investigate the case expose history. And describe principles of contact investigation for an infectious disease that's spread from patient to patient. Like for instance, for the infectious disease, now we are talking on COVID-19. But it will be the same if there are any other outbreaks that cause the infection will spread from patient to patient. You can use the same technique how to interview. And the case investigation, how to go about. And understand and complete the case investigation report, which is very important. A lot of data will be analyzed based on that form. Most of the times, as we've seen now from the reports coming in from the field, the CIF is incomplete. Some of the information that is important are missing. So understand that how the information on the CIF, its relevance, because that's the data that is needed for that to help target the response. So like I said, this session will be focused on case investigation principles for COVID-19. And it cannot apply also on other outbreaks, like for measles, or the previous outbreak that we had for polio, pertussis, cholera, we had some years ago. Before we conduct a case interview, we need to identify who these cases are. And we use case definitions to help us identify cases. And the requirements, we aim to, case definition requires specific set of criteria based on what we know already about the disease or the illness or the event that is happening. And then we aim to standardize case definition so that the definition is used by everyone, so we know people who are identified as cases are meeting the specific criteria. This is very important and has implications for how we interpret our data. So case definitions usually comprise of clinical mainly based on the collection of syndromes, signs and symptoms, or based on the laboratory findings. So during an outbreak, we add in time when the outbreak occurs, and then the place, the location, and people to identify cases who could be part of the outbreak. So it's important that we know the case definition, and case definition can be changed over time as more information is about the disease obtained from the exposure and the transmission. So here the case definition for COVID-19. This is the current definition that we are using. The National Department of Health is using. For a confirmed COVID case, is defined as a patient, whether alive or dead, disease with a laboratory confirmation. Laboratory confirmation using the 3 types of tests that is currently being used, either PCR, gene expert, and lately we are trying to roll out the antigen RRT test. Who may test using those 3, test positive for COVID-19, irrespective of their clinical signs and symptoms, where the patient is at the symptoms or not, but as long as the test result, any of the 3 is positive, then that becomes a positive or confirmed COVID case. Like I said, this is a case definition for suspect measles. Okay, for COVID-19, like previously I said, for case definition, it can be through clinical or laboratory confirmed. For COVID-19, it's a clear water that is confirmed by laboratory using the 3 different tests. Like for measles here, we can say it's based on a clinical set of criteria to identify cases of measles. So for suspected measles case is patient with fever plus, that's the features that if any, during an outbreak you go and if you identify any patient with these features, then you group them and they become like a case. This is during an outbreak investigation. We conduct case investigation when the student learning. This is a case definition for an outbreak response for outbreak case definition. When you are called to go and attend to an outbreak, so outbreak case definitions can be used in outbreak investigation, and they include patient, place, and time. So patient who is affected by the whatever type of infection or event or disease or illness, and place, where is it occurring, and that time, what time the outbreak started. Case investigation, here we conduct case investigation to identify whether patient may have been exposed to the disease and who they might have spread it to. We look at where and from who they acquired the disease. You are trying to identify the source of infection. And then to who the person who is infected may spread the disease to, the context. So the objective of case interview is we want to determine the important dates. So when we conduct case investigation, is basically to determine the important dates such as the onset date, when the patient develop the symptoms or become sick, the incubation period and the infectious period. And we want to identify the potential source of infection in order to establish control measures that will prevent future episodes of the diseases and identify context of the positive COVID case in order to quarantine and monitor them to reduce further transmission or spread of the virus. In the case investigation flowchart, once you get you are called that or you receive a report of a case, then this will be similar for other diseases where patient-to-patient transmission occurs. It is important that during the preparation phase for the RRT members to be aware how the case investigation process will work for the specific HALA they're investigating and to ensure the steps are clear to all involved in the response. So whoever the team members in the response team, you must be well updated and informed in what areas you will partake during that investigation. The way the team is informed of the approach and can answer questions from the community. For COVID-19, these are the steps that we follow for case investigation. Okay, once you receive a report of a positive case, immediately at the diagnosis, when the case is confirmed, then you receive the report. Immediately, the investigation team, you mobilize and interview the case in order for you to identify context. After your initial interview and you identify your context, you review your contact list again because there will be many contexts given by the case. But you have to review the list again and you have to narrow it down who are the real contexts or true contexts that you will monitor them. Because they will be the ones high risk that if we don't quarantine them, they will spread the infection to others. So within 2 days after the diagnosis, you implement monitoring database and actively daily monitor the context once you quarantine them. In the investigation, there are 6 steps involved. First, the main steps in case investigation are identification and information and demography of the context. Illness information, these important dates. The important dates are onset of the symptoms will help you. You calculate the incubation period and the infectious period. This is very important. The background information on the case is exposure history during the incubation period. That's where it's being exposed. You will identify the context during those incubation period up till when you develop signs and symptoms, and then you during the infectious period. And then contact line listing during the infectious period, if this is appropriate for the alert you are investigating. And then you complete and submit the case investigation report. Identification information and demographics. Okay, what type of demographic information are we interested when we investigate a case? Yeah, I'm asking that.
Hello. Can you hear us? Hello.
Hello?
Can you hear us?
Yes, Gibson, we can hear.
Okay. Okay. There's a question coming.
I was just asking what type of information do we ask when we investigate a case to get more information?
Where the particular case come from, his or her location, and also the particulars, his or her personal information, his age, and his location.
Some of the background information on the case, okay? The case ID, when you want to do case investigation to investigate the case, you get the information from the positive case. Okay? Name of the patient, gender or sex, the date of birth or age. If it doesn't know the date of birth, at least you get the age. His residential address. You know, like some people have too many addresses, so they move from one place to another. So you have to ask the case, is current place of residence, is he here for how long, or is he going to move out? So at least you get more than one residential address if he's going to move out. You know, sometimes maybe the person just come for a week or two and then he moves out, and then you lost the case without knowing his next residential address. So when you take the case address, you have to ask, is he a permanent resident of this place, or is he here or she here for an event or just visit and then he's going to go back to where he or she lives. So address is very important so that will help us in contact tracing as well. And then you get the information, the illness information, determining those three important key dates. The onset date on which the case had the first symptoms present. The date of the incubation period. Incubation period is defined as the period is the time frame in which a person with COVID-19 can transmit the virus to others. They may or may not have the symptoms. They can be asymptomatic. And the infectious period is the time frame in which the patient with COVID-19 can transmit the virus to the others. Again, the patient may be symptomatic or asymptomatic. So those three important key dates will help you to calculate your timeline and try to establish and identify those contexts within that timeline. So the incubation period and the infectious period will differ depending on what alert you are investigating. You will need to refer to the outbreak manual and then specify the for contact tracing. The SOP for contact tracing is under review. There's some changes. It will come out after the review and they approve. So you refer to different SOPs for under different subclusters, like for RTT, contact tracing, etc. Okay, the timeline of infection, the infected contact. Okay, in this slide shows the timeline of the infected contact. From the incubation period up until the patient develops signs and symptoms. So incubation period, like we said, it's 14 days, 2 to 14 days. But on average takes about 5 to 6 days. So in this timeline here on day 14, we expect the patient to start show symptoms, but this depends on each individual, the immune system. Some can be sick as earlier before 14 days, but on average is 5 to 6 days. And then when the patient, a day or two before the signs and symptoms started, this will be your infectious period. So during that day, 14 days, develop signs and symptoms, and then we know that we count 14 days again to be like the infectious period. The red, okay. Sorry, I should have put that red. Anyway, so like I said, 2 days before the patient shows signs and symptoms is the infectious period. Like I said, infectious period, the patient will, whether he or she may have signs 2 days before the patient is already infectious, 2 days before he or she started developing signs for COVID-19. He or she is already infected. So if we come in contact within that 2 days before, up until that 14 days period, that's the infectious period. That's the period that whoever he or she comes in contact or exposes to, the risk of spread is high. The background information on the case, the type of information that you will get to, identify your contacts. So when you start to interview the case, it's important to help you with your investigation and to be able to draw conclusions around the exposure and the possible transmission. You ask about how many people in the household that cases live with them. So you have to ask him to name them all, if possible. If they're a family, then he will remember all. But if he's out somewhere, he may not remember all the context. So, but if the case can provide you phone contact numbers for his close contacts or whoever is living with him in the household, will be great, because you need to call those contacts. And some people have more than one household. So you have to ensure that all households are covered. If he is working, you have to ask him, working or not, you have to ask him, is he working or not? If he's working, then where does he work? What days does he work? And time of the day. And what place do the case typically visit during the week? And also, you ask him about his travel history. If the provincial, domestic, or international. So it depends on whoever the case is. If it is a national, you ask. If it is a expatriate, you ask about the travel history. And then which are the friends or events that the case might spend time with or come in contact with, or events that he may participate in. You may also ask to trace back to identify the context that is probably exposed to. The exposure history over that's during the incubation period. You ask, have you been in contact with a non-COVID case? If yes, then ask for name. You get the further details. And then you have to, all these contacts you identify during the incubation period, you list them down. But later you will narrow down your list. So during the investigation, interviewer interested in finding out specific information about possible exposures. These are the type of information that you will ask. If the case come in contact with a case, if yes, then you ask for the name of the case and the date of last exposure. Okay, so some case, those positive cases, some may be willing to disclose their information. When you call their contacts, they said, okay, you can tell them my name, and then, but some may not want you to disclose their ID to their contacts. Then you don't need to name the case. So by finding out where this person may have been exposed, we look for other cases that may have had the same exposure. Once we find the source, we can implement control measures to stop further spread. We find the source by conducting source investigation, and this consists of asking persons where they have been, who they have been in contact with in the past 14 days. The 14 days is the incubation period before he or she develops signs and symptoms. Okay, this is a scenario here. A 58-year-old male that lives in Pocondeta has been confirmed to be positive for COVID-19 after having nasal swab specimen collected on April 24th. For the incubation period. Yeah, incubation period, yeah. Okay, this scenario here is to help you to calculate the incubation period. Okay, this is the scenario one. Okay, this is for the incubation period. You have to identify the incubation period and the infectious period, I think.
Yeah. So then you can take it back so they can see the scenario. Now back to the scenario. So you have to calculate both the incubation period and infectious period for this case. So we'll give you a minute to tell us what is the incubation period and what is the infectious period. When you're ready, you can just call it out. You can tell them when they're ready.
When you are ready, you can just call out your answer.
24th of April. The incubation and infectious.
Say it out, when is the infectious period and when is the incubation period? Yeah, I'm not sure if you're listening to that.
April, May 1, around April 30.
And when is the infectious?
The incubation period could be from the 8th up to 8 to 10. And the infectious period is from the 22nd to the 24th up to maybe the next 14 days. What did you say, guys? Tim say, what is the incubation period?
Incubation lasts from the 8th of Jan.
24th is positive, right?
This incubation period.
I say that.
And then infectious period. Infectious period.
24 to the 7th May will be the incubation period. Second to 8th incubation period.
The incubation period is from the 8th of April to the 22nd. What do Tim say? The infectious period is from the 22nd to 22nd to
7 days.
29.
7 days.
Hello?
Yep. So what's the incubation period?
From the 8th April to the 22nd. 22nd April. What is this?
24 to the 7th May.
The incubation period is the time when the infection gets into the patient. From the time of clinical signs and symptoms is the infectious period. Okay, so far. Incubation period is the time that the virus gets into a patient. Until
To
the 10th. Second to the 10th. We still having all kinds of dates here.
Okay, let's it will be. I just is it on the phone? It will be on the 10 to 11. Yeah, I just calculated here. Okay, here in the scenario, I didn't tell us whether the patient was symptomatic or not, but we have to base our calculation based on what? the test result.
Result and the date.
Yeah, date.
Tested positive.
Date tested was on the
24th.
24th. Then we calculate how many days back. 14 days back or 7 days. We said the incubation period still remain at 14 days. But on average, patient can be symptomatic at 5 to 6 days. But during the case investigation and we want to identify context, we still calculate 14 days back. So it will be 24th, we go back 14 days. It will be on the 11th or 10th. 10th April. Okay. Note that time, note that date on your timeline. And the infectious period. What will be the infectious period? Is everyone agree with the incubation period? Let's get this correct because it's important.
No, we do it again.
Because in case investigation and contact tracing, your timeline is very important to help guide you to identify contacts.
Yes. 114 days. Yes. So that's on the 10th.
When will be the infectious period?
Infectious period is
From the 11th
7
to the
days.
24th.
Infectious period is 7 days.
11
to the 18th, 19th.
10th April.
The infectious period, if you can remember the timeline, is 2 days before the symptoms or 2 days before the test result or the patient was swabbed, test done. And then you calculate 14 days.
8 to the
It will be 22nd and then you add 14 days. Then gives you go into the next month, May. Is it clear?
6th of June. May.
The timeline is very important for them.
So the 5th or 6th.
If my understanding is correct, that's 24th, take away 14.
That's time to
That's the
incubation.
incubation period, minus 2 again, plus 14 to get the infection period.
Okay, we said for incubation period is always 14 days back. You go back. For
Okay,
incubation, for infectious period, you will add 14 days forward. Okay, for in this case scenario, it was not symptomatic, but it was tested 24th. That's the time that you know the case was positive. So it was not symptomatic, but the test was positive. So you calculate 14 days back. You want to identify the source of infection, where he got the virus from, and then it took him that period, the incubation period, before it became symptomatic or the test becomes positive. So in the incubation period, you have to calculate back. So it's 24th, the test result, I mean, it was tested positive. So you have to calculate back because that's the time that it took him until the test positive. It was not symptomatic. So you have to calculate 14 days back.
Does everyone understand the difference between infectious
Yeah.
period and incubation?
That's
period?
it.
That's clear? Great.
And then infectious rate will go already. 6th of you'll go forward. You go forward. So it's
So it's on the 10th,
around 6.
then for infectious period, it's another 14 days from the 10th.
10 minus 2,
10 minus 2, and then
8.
which is 8.
Okay,
Hello?
okay, let's get these two terminologies clear by meaning. Incubation period is the time frame when the patient come in exposed to a positive case, and then it took him that number of days before he is symptomatic or the test result is positive. Is it clear?
Yes, that's clear.
And the infectious period starts from the 2 days before the onset of symptoms or 2 days before the test is tested positive and until 14 days. That's the infectious period. That's the period that the case is highly infectious and is susceptible or high risk to spread the virus to whoever it comes in contact with. Is it clear now or?
Yes.
Okay, 24 take away 2.
Actually, the incubation period is about when they might have been exposed
24
to
take
the
away
virus. So we're looking at
14.
we're looking at things backwards,
2.
where they might have got the virus from.
Then,
And then 14
and
days.
then you get 22. No, 14 days.
14 days.
Down.
Plus 14.
So it will be down to what? 8.
First or second May.
Yeah,
6th of May.
it will go on the 8.
Now that the person is being tested positive on the 24th, we minus 24 by 2 and then get 22nd.
Uh-huh.
So
That's for the infectious
the
period.
infection period is from the 8th to the 22nd.
Yeah, 8 to the 22nd.
The timeline.
timeline.
I got to ask the timeline.
Okay, thank you.
May
Now we understand.
6th to the 8th.
Okay, look,
Clear?
guide them through the timeline.
So you can see here the person is feeling unwell, they've got funny things coming off their head. That's the person who's feeling symptomatic, they're coughing. And then if you look backwards, you've got the incubation period. So that means they could have been exposed to COVID somewhere there, they've come in contact with someone with COVID. But we don't know when. So we're safe and we say anytime in that 14 days, they're in contact with someone with COVID. So is that clear? That we just take 14 days because we're not sure exactly when they got contact with someone. We'll also share the slides, but yeah, it's good to have a photo on your phone as well. It'll help you explain it to other people when they ask. And for COVID, we think somebody is infectious from 2 days before they develop symptoms. And then for as long as they've got symptoms and a few days later. So that's why we consider this long infectious period here, which starts 2 days before they become symptomatic. And we're using the example of COVID because that's relevant to us now. But it's important with whatever disease you're responding to, whatever alert you're responding to, that you think about incubation period and infectious period, because it will help with your investigation. So whether it's cholera or measles, it's important for you to understand before you go on your response what these periods are. It will help you with your response. Okay. When you do case investigation training and contact tracing training, you will go into this in more detail and you'll have lots of more examples to go through. So you'll be much more confident in calculating these dates. In this session, we just wanted to introduce you to these terms and show you how it's relevant for COVID. But when you get more training on case investigation and contact tracing, you'll get given lots of scenarios to practice calculating the incubation period and the infectious period. And then you'll become experts and you can teach everyone else. Is that okay? Does that diagram make it a bit clearer for you?
Yes, yes. What did you answer?
2 days prior to the symptoms onset, 14 days after.
Okay, good.
So if you look at this person, if that's actually what was the date, 24th.
24th.
So if this person was actually the 24th of April, then you can see now how we're counting backwards for the incubation period to the 10th of April. And then we'll be counting back 2 days and then forwards for the infectious period. So it'll be from the 22nd of April, 2 days before their test, all the way down to 14 days after their test result. Is that clear?
14 days, what?
Is it clear now? Still confused?
Yeah, just you can look at the expression on there.
Can you repeat that again?
Sure. So if you look at this person, you can see the person here on day 14. If we say that that's the scenario, so this is the man he's 58 and he had his test on this day, and then we consider him infectious. Sorry, we consider that his incubation period 14 days before he had his test taken. Is that clear? This yellow line up on the screen means he could have been exposed to COVID at any point in that time. We don't know. So we consider that his incubation period. So we'll be wanting to find out information of where he went and who he met with and any travel he's had during that time, so we can identify where he might have picked up COVID from. And then on this date that he was tested, we consider 2 days before that, so that'll be the 22nd of April, was when he became infectious. And then for 14 days after his test, we still consider him infectious. So what's 14 days after the 24th of April? Anyone got a calendar on their phone? What's 14 days after the 24th of April?
So our answer is our answer is 8. 8 to 22nd is the infectious period.
Seventh of May.
7th of May, is it? 14 days after the 24th of April. Did everyone get 7th of May?
But it's 14 days after the test results.
14 days after 22nd of April.
Infection period is from,
Yeah.
from
That's the
the
infectious period.
8th right after the
8th of May?
It will be 7th of May.
Incubation period is viral load in our body.
14th will be 6th May.
So 6th of May.
The viral load in my body was spread to risk. Yes.
Infectious period is very important. They need to know because
Yes, ma'am. Incubation period, I'm positive. I'm still about the 14 days. Now, infectious period is
14 days.
for me to spread to risk.
That's all.
so they will.
Okay.
So this tells us whether
So this for this case study. Hello.
yes,
For this case study, the infection period is, if I'm correct, infection period is 8 to the 22nd.
No.
Oh, okay.
yeah, from 22nd
22nd.
of
April.
April to the 8th of May, yes, they're infectious. So you want them in quarantine. So this is why it's important for us to calculate this, because if they're infectious, we don't want them coming in contact with any other people. So we want them to be quarantined during that time so they can't pass on the virus.
Okay. I think maybe the same statement. On the 8th of April
They're
to
going.
the 2nd of April, I have not been tested positive, but I have signs, symptoms of COVID-19. On the 24th, I got a swab and it turned out to be positive.
22nd was symptomatic.
What day did you get symptoms?
22nd. Then test result. Then we have to go back 20.
So my understanding is that infectious period is from the 8th to the 22nd, which I have come into contact with certain people. And the surveillance team will have to question me, Mr. Gitton, where were you within the last 14 days? That's from the 8th of the April to 22nd. And I was with Mary, John, Luke, whatnot. And
What happened on the 8th of April? Is that when you developed symptoms on the 8th?
that was the infectious period where I came in contact with Prakash or other people.
Incubation period.
Yeah, I think the incubation period you take from the first day of symptoms, not from the first day they were infectious. So if the symptom onset was the 24th, so if you go back for 14 days.
In this case scenario, it's not symptomatic.
Go back to
Or the swab. If they're not symptomatic, it's swab.
We based on that swab day, yeah.
Yeah,
So
yeah.
in our example, we didn't have symptoms.
That's why I was
We had a swab, so we take it from the date of the swab.
Okay, the swab.
If he had symptoms,
I think
we would take it from the day he became symptomatic.
Yeah.
the swab was taken later. It has to be from the date of the onset. That's when the person also becomes infectious.
Yes, I agree. If the person has symptoms, it has to be from the date of symptoms. So if the person has symptoms, we take it from the date of symptoms, not from the date of the test. We take it from the day they first started testing. But this person in the scenario that we used as an example didn't have symptoms, but had a test result. So that's why we took it from the date that the swab was taken. We might change this example in future because I think it might be a bit confusing. We'll include an example with symptoms next time. So if the person has symptoms, it's correct. You take it from 14 days
based
before
on
the
the test result.
development.
That day that the patient was.
Is that clear?
Lunch and think about it and come back.
The SOP.
Ask them.
The copy of the SOP for contact.
Do you have a copy of the SOP for contact tracing at the product?
Can we do the exercise again?
Can we take a break about it, come back and continue?
Or have it.
Have you got lunch? Have you had your
The
lunch
oral team
tomorrow?
is
Sorry, Alex, sorry.
Confused.
Alex, feel free to talk.
This is important. And then contact tracing starts on there.
Eloise, feel free to talk.
the oral team, I believe, is correct because from the date of the onset, when you actually look at it, that's when the person becomes infectious. So it's not from the date where they collect the swab because it can be probably 2 or 3 days after the patient is infectious. The swab, when they collect it, can become positive. So we go back to the date of the onset. That's when the person becomes infectious. So you start looking back from there.
They didn't get the scenario.
Yeah, I think what we'll do, I think that's right, Alois. We'll take our lunch break and maybe we'll come back. We'll add a new slide with 2 scenarios. One scenario is when they have symptoms, and then one scenario is when they're asymptomatic and they come back positive. So is that okay? Gibson, do you have your lunch in our?
Yes,
Okay.
I think we
So
talk about it And we should come back with a fresh.
Yeah, let's take 30 minutes for lunch. So can we come back at 2 p.m.?
Okay, thank you. Thank you.
Because we're running late. So if we have a quick lunch, grab lunch, we'll come back at 2 p.m. And it's okay for you to eat while we're doing the Zoom. It's okay. So we'll see you back here at 2 o'clock.
Okay, team, go forward.
If they have the SOP for contact tracing, it's all in the SOP.
Yeah, it's a tricky one, this one, isn't it? It's,
With the
I can't hear you. Are you speaking?
So how long have you been on the started?
Our friends, are they coming?
I was authorized to attend the training for 2 days. By the RRT, this is my last day. Tomorrow I'll be back to work. But tomorrow is my training. What is that tomorrow?
Yeah.
All right. All right, everyone. Is everyone back? I'll just stop sharing. Hi, Gibson. Have you got all your team in place?
Yeah, unfortunately, we had a power sabotage. We left our conference room and now we came up to the hospital.
Okay, you had to relocate.
And some of our members are still walking up.
Okay.
So once they come, I came in here and I'm setting up our system here at the hospital conference room.
Okay, no problem. So you need a couple more minutes?
Yes, how many so far? We are 2, 4, 6, yeah. We need another 6 to come. They're still coming.
Okay. Just let us know when they're all there and ready to go, Gibson, and we'll get started.
Okay.
We're running quite late, so we don't want to delay.
Okay, just go out, check on them and get them move up quickly.
Great, thank you.
That will be the one to put up. I can't put it on. It will have to be done.
Hi, Gibson. Can you just give me your phone number to send the credits through to?
717
Yep.
30427.
Perfect. 717-30427.
That's correct.
Okay.
If the team is ready, we at the majority here, we can start.
Okay. Perfect. I'll just send this off to you.
That what is the windows are telling us to put it up so we can. Yesterday they gave me about 5 gigabyte in the morning. 50
Okay. That should have come through, Gibson.
Yes, yeah, good.
You got it there? All right,
Yes.
and you have everyone ready to go?
Yes, majority are here.
Okay, so what we'll do, we'll just do a quick recap on the incubation period and have a little discussion around that in relation to contact tracing. Let me just share the screen. I think it's this one. Okay. Do you see the screen? Okay.
Yep,
Yes,
it's in
yes.
PowerPoint. Yep.
Let me do in presenter mode. Oh, that one. Let me get to the right screen. This is the one. Okay. All right. So we have this scenario again. We've updated the dates. And what we want to do is based on their date of symptom onset and We want to calculate the incubation period, and we want to calculate the infectious period, and then briefly discuss why it's important to know these two time frames. So let's just do a quick recap of this. And this is a new slide, but it's saying exactly the same thing as the previous one. So we have here on day 0 is our symptom onset. And this is what Alois was saying, that it's important that if we have a symptom onset, then we definitely base all our calculations on the date of their symptom onset. Now, the exception is if they don't have symptoms, if they're asymptomatic and they're positive, then we base our calculations on the day that they had their positive result. But let's ignore that for now. Let's go with somebody who's symptomatic. This will be the most likely scenario. We have someone who has a symptom onset. And what we want to do is calculate the incubation period. And that is minus 14 days. So the incubation period is minus 14 days from the date of their symptom onset. And their infectious period is a little bit more complex in the fact that it's plus 14 days. So they're infectious for 14 days after they have their symptoms, but they're also infectious for 2 days before they have their symptoms. Now, this is for COVID. Each disease is different. We're just focusing on COVID. This is what it is for COVID. So if we go back to this slide, this is the same thing. The yellow strip on day 14 on our calendar days, that is the symptom onset. So we go back for 14 days and we get the incubation period, and we go forward 14 days and we get their infectious period, and we add on minus 2 days. So 2 days before their symptoms, because they get infectious before they actually start showing their symptoms. That's why COVID is actually very difficult to control, because people might be spreading the disease before they have any symptoms, before they know that they are actually infected. So that's the minus 2 days, or the 2 days before their symptoms plus 14 days after their symptoms is their infectious period. So let's do the calculation. We'll go back to this scenario. We have a 45-year-old woman. She develops a cough on the 15th of May. And she goes to the clinic on the 20th of May and has a swab taken for COVID, and it's confirmed to be positive. So based on these dates, what is her incubation period? So we're taking a hypothetical date of May the 15th. What is her incubation period from when to when? So remember the date, May 15th, and we'll go perhaps to this slide here. So May 15th is their symptom onset. So they develop cough on May 15th. So if we look at our phones and look at our calendar on our phone, what is it if we have May 15th and we minus 14 days? What do we get? What date?
1.
Okay. Here we go. We have a calendar here. So we have, just pretend that it's May, but we're going for 15th of May, and we want to minus 14 days. So minus 14, let me see if I can.
First.
I don't know if you can, I don't know if you can see anything.
Yes.
It goes back to the first, doesn't it? It goes back to the first.
That's right.
So the 15th, if we go back 7 days, we get to the 8th. If we go back another 7 days, we get to the 1st. So our incubation period is from the 1st to the 15th of May. 1st to the 15th of May. Oops. Is that clear with everyone?
Yes.
Now, why is it important that we understand this time period from the 1st to the 15th of May? Is the incubation period, but why do we care about this period? What's important? As a RRT, as a group of investigators, why do we care about April or May 1st to the 15th? Why do we care about the incubation period?
The past travel history of the person we are trying to investigate.
Can you repeat, Gibson? I didn't quite catch it.
We want to know the history of where the particular person was within the incubation period.
Yep. We want to know, why do we want to know where they were going during the incubation period? What are we actually looking for during our investigation into the incubation period?
Because at that time, this person was really, has been as met along with other friends whom we might call them up as, and do contact tracing to see
Okay.
like awareness and all these things.
The chances of this were passing on to another person is high because it was contagious by infectious period.
To establish the context within this period, of whom that particular person has come in close contact with.
So let's just pause there because during this period from the 1st to the 15th, we're actually looking for how they got infected. How did our case get infected? So we call this a downstream investigation. So we're going from the date of their symptom onset. We're looking backwards for 2 weeks. We call that a downstream investigation, looking for how did they get infected? Who were they in contact with that was positive, that passed the virus onto them? So we're looking for how did they get infected? Oh, just 1 second.
Looks like James has to take a call. Is that clear to everyone? Oh, James, are you back?
Yeah, sorry. Barry, we're just letting Barry back in.
Oh, sure. Yeah, go ahead.
Is that good? So the downstream investigation during the incubation period is an investigation where they got infected. Where did they get their infection from? Now, the upstream investigation, this is the one going forward now. This is the one where we want to find out the contacts. But before we look at that, let's just go back and calculate. Let's calculate the infectious period. For some reason I can't. There we go. So let's go back to our timeline. So they have symptoms on the 15th, and they are positive on the 20th. So we've done the first one. We've identified the infectious period, the incubation period. Now we want to identify the infectious period. So how do we calculate the infectious period?
You count 2 days back from the incubation period within 14 days forward.
Exactly. Yep. So where May 15th is our onset, what is our infectious period?
15th. On the 15th May.
Last 14 days.
Should we go back to the calendar? Let's go to the calendar.
Yes. 2 days back is 13th.
That's right.
Last-
Yep.
And
So we
then
go
we
back
count
2 days to the 13th.
another
And-
14 days upstream.
So
That
what do
should
we
be
get? What do we get?
27.
26.
It's actually not 14 days after the 13th. It's 14 days after the day of their onset, which is the 15th. So it's the 15th of May plus 14 days. So it's actually from the 13th to what's 15th? The 15th plus 2 weeks.
28.
29.
Did I hear 29?
Yes.
Yes, the 29th, the 29th. So our infectious period is May the 13th to the 29th. Let's just go back and have a look at this one. So you see this one, you go back 2 days before the symptom onset, and then you go forward 14 days from the date of their symptom onset.
28.
Is that clear for everyone?
Yeah.
Okay.
Okay, ma'am.
So why is it important to know the infectious period? Why do we care about the infectious period?
This infectious period is important to us at the time person is likely to infect others. At this time, we need to do our interventions to isolate or quarantine or anything, especially with COVID.
Yes, that's correct. Their infectious period, we want them not to spread the virus to anyone else. They're infectious. We want to make sure they're in quarantine. And what else do we want to do? Someone mentioned it earlier. Contact tracing. Contact tracing. That's what we want to do during the infectious period. So we want to do two things. We want to make sure they're quarantined so they're not getting in contact with anyone, but they may have already been in contact with some people before we get to them and before we get them in quarantine. So we want to know exactly who they were in contact with while they were infectious. And we need to identify each of those people, and we need to manage each of those people as well, because they could be incubating and they could become a case. So think of it, I like to think of it as the downstream investigation that's looking backwards to see where did they get the disease from. And then upstream investigation is going forward to look at who did they potentially expose while they were infectious. So the contact tracing bit. And we need to make sure our cases are in strict quarantine, that they're having no contact with anyone during their infectious period. Or if they do have contact with people, that the people are healthcare providers that have proper PPE. So these are the two critical periods of time for our rapid response for COVID. It's also true for other diseases. We do contact tracing for Ebola, for example, or other diseases, TB. The same sort of principles, the incubation period and the infectious period will be different for different diseases. But the reasons we want to know these periods, and what we do is the same. All right, I'll leave it there. Is there any questions before we move on? Okay, I'm going to stop sharing. Is that clear for everyone? I know it's a little bit confusing.
We'll do another example in the contact tracing.
Okay, we're going to have another example in just a sec on the next section, which is looking at contact tracing. All right, I will hand back to Bernie, and she's going to take us through contact tracing. Let me just share the screen. Contact tracing. Share. Yeah, we can get rid of that. Okay, over to you, Bernie.
Okay, thank you. Okay, now we'll go on to contact tracing. So if you already investigated the case, and now you identify the context using the tool, the timeline that you had. So contact tracing is very important in any outbreak response, because we want to control the outbreak and reduce the transmission and then get the outbreak under control. So for COVID-19, contact tracing is a very important strategy in the response measures. And why do we do contact tracing, or why is contact tracing very important?
Stop the virus from spreading.
Can you please come closer to the laptop? We can't hear very well. We can hear you calling out answers.
To identify the context and contain in order so that the to stop the virus from spreading.
Okay, identify the context, okay, and to stop the virus from spreading. Okay, that's correct.
Device control measures.
What was that one?
Device control measures to contain the
Device control measures.
Oh, yeah.
Yeah. Okay. So the basic idea, or generally contact tracing, we really want to interrupt the spread by breaking the chain of infection or transmission. So these are the two diagrams, one on the left and one on the right. So if on the right one, there was contact tracing initiated. So one of the contact was identified and quarantined. So you see the X there. He was quarantined, so he couldn't transfer the infection to his other contacts. With COVID-19, one case, a positive confirmed case, can spread the infection to the virus to two other people. So as illustrated here, so we at the left diagram, right diagrams, when one of the contacts was quarantined, it stops from spreading the virus or transmit the infection to his other contacts. And the other one was not identified and not quarantined. You see, he started to spread the infection or transmission. And that's why contact tracing is very important. We identify contacts, quarantine them, we break this chain of transmission. And then indirectly, you will see that there are cases will start to reduce, and the outbreak, you can control the outbreak. So like in contact tracing, we want to identify those who are infected with COVID. The source investigation or the case that was confirmed COVID positive. And also we want to identify who are potentially infected after having contact with the case. Those who are potentially infected are referring to those contacts within that infectious period during the time frame of that infectious period. These are highly high risk contacts, or these are potentially infected ones that they can spread or transmit the virus when they come in contact with others. Okay, let's remember the infectious period is the time frame in which an infected person can transmit the virus to others. And the time frame in which contacts can be generated. So remember the exercise, the scenario, and the timeline that we discussed. So infectious period begins 2 days before the symptom onset and ends 14 days after the symptom onset. And this is the timeline again, just to get more clear understanding. Always when you establish your investigation, you have to do a timeline. Calculate the incubation period, calculate the infectious period, and then you know which you quarantine those contacts only within that, identified within that infectious period. These are the potentially infectious people that if they are not quarantined, they're eligible to spread the infection or the virus to others they come in contact with. How do we identify contacts? There are criteria used that will help us to identify those that meet the contact criteria. So contact definition refers to the case infectious period, those who are within that infectious period according to the timeline, depending on what type of case we investigate, and we calculate our incubation period and the infectious period. So we identify the infectious period and then identify the date of symptom onset, calculate 2 days after date of onset, and 14 days added on. That's the end date that when we identify the contacts, they will be quarantined within this period. So the period between the start date to the end date is the infectious period. That's for the symptomatic patients. For asymptomatic people, we look at 2 days prior to the positive specimen collection. We'll use that to calculate our infectious period. So 2 days prior to the positive test until 14 days after, they will be in quarantine. So for COVID-19, A contact is defined as anyone with the following exposures to a COVID case from 2 days before to 14 days after the case symptom onset, or until the last exposure to a COVID-19 case, whichever comes first. Okay, in the first scenario, you were confused because patient was not symptomatic, but the test came back positive. The test came back positive. So here you will use that test date because it was not symptomatic. The case in the scenario was not symptomatic. So that's what the case definition of COVID-19 defined. It's just the same. So, any questions?
Define this anyone following exposure to COVID-19 case from 2 days before 14 days after or until the last
So for a contact now, you will concentrate more on those contacts who are exposed during the infectious period only, not the incubation period. The incubation period, you are trying to identify the source of infection, where that case was exposed to, and he probably come in contact with that infected case, and then later on, he developed the signs and symptoms or became sick. But in contact tracing, you focus on the infectious period, only the contacts identified during the infectious period. I continue. These are the criteria for us to help us to identify the contacts. Those who meet the following criteria at any one time during the infectious period of the confirmed COVID-19 case is classified as contacts. So those descriptions there refer to the contacts, criteria for the contacts. So contacts are people living in the same house as the positive case, or having face-to-face interaction with that case less than a meter for 15 minutes or more, spending 2 or more hours in the same enclosed space, or direct physical contact with the COVID-19 case, or someone who is providing direct care for a COVID-19 case without using a PPE. So if your contact identified and they fall in one of these two, one of the 5 criteria here, then they are eligible contacts that must be entered into your line list for contact for you to contact monitoring. So contacts to consider in summary, like lived with, or you worked with, you cared for, or you socialized with, or you attended the event with, or traveled with. So in those settings, or in those scenarios that the contact has been exposed to a case during those events or during those times. The basic steps in identifying close contacts, after your confirmation of a COVID-19 case, you receive the report. The investigation team is mobilized and you conduct the case interview. You interview that confirmed case. So during the interview, again, always use the timeline to help you calculate the incubation period, the infectious period, have your contacts listed. Your investigating team list all the contacts within that infectious period only. if you want to include those contacts that he has been exposed to during the incubation period, you will have a very long list. So you have to narrow it down only to those who are exposed to during that infectious period only. So within the first 24 hours after confirmation of the case, you have the list. Once during the interview, you may list all the case. Again, you review the list again. And then for the context, like I say, you will exclude those during the incubation period. Prioritize, you focus it down to those who the case was exposed to during the infectious period only. And then during that infectious period, you can further reduce, again, based on the contact criteria. When the case was, if some of the contacts did not meet the contact criteria, you will start to exclude them. So you narrow your list down to those who are high-risk contacts that met the contact criteria and who were exposed to the case. And then you inform the individual that you have been exposed to the case, and during that period, that is, you are at risk of getting the virus from that case, so you need to be quarantined. You inform the context. And you have to explain why it's important for the person to be quarantined. So within 48 hours after confirmation of a case, contact tracing must be activated now. You have to start daily monitoring of contacts in the quarantine. And those contacts has to be listed on the line list that you have. And on daily basis, the contact monitors to the daily monitoring or monitoring on alternate days. So during the monitoring, you ask them basically on the symptoms, signs and symptoms. If they have fever or cough, sore throat or shortness of breath or any other signs that or symptoms they develop, then the daily monitoring, whoever is doing the contact tracing, contact daily monitoring records on the monitoring, daily monitoring chart or the line list. For the quarantine period, all contacts meeting contact criteria must be separated from others by quarantining at home. Okay, it depends on each setting or where you are. But for quarantine, we don't have the facility for quarantine. We advise for quarantine at home. Only those who are positive, then they are isolated. So quarantine is different from isolation. Isolation is for positive cases only to be isolated. Quarantine is for the contacts who have been exposed to that case during that infectious period of the case. So for each contact, establish the quarantine period by determining the last date of contact with the confirmed case. So like it goes back to the timeline that you will be using to calculate. 14 days after the last date of contact, that's the quarantine end date. And date between the last date of contact and 14 days later is the maximum quarantine period, unless the patient during the quarantine period develops symptoms, then the patient must be not isolated yet, but during the quarantine period, when the contact develops signs and symptoms, then inform the RRT team to do testing. If the test comes positive, then the contact has to be isolated. Remove from the quarantine to isolation facility. So quarantine period is only up to the quarantine end date. So depending on when the contact is identified, the remaining quarantine period may not always be the full, not 10, but 14 days. Okay, this calendar is a mistake. We edited the new one, but it was not slotted in. It's this was the duration of the quarantine. So on the 4th was the last day of exposure, and then we calculate should be 14 days, and contact will leave the quarantine on the 19th, not 15th. Sorry, should be on the 19th. Should be 19, 15 because of 10 days, but the SOP has not come out yet. So for now, we will continue with 14 days unless the revised SOP is out. This is for the contacts in quarantine. We still stick to 14 days until officially SOP for contact tracing, the quarantine comes out. Contact tracing, but part of it, quarantine is inside.
Okay. Good afternoon, Gibson and team. This is Emmanuel. Just letting you know about the contacts, the quarantine, how you should quarantine a contacts. The contacts are identified, and the time that the contact has come in contact with the confirmed case within the infectious period that you have calculated will be the date that you will start counting until 14 days where they will be quarantined. You clear? So
Yes.
if a contact comes in contact with this confirmed case on the 6th, then the 6th will be the first day of contact. So you will count from there 14 days, and then you will quarantine them. If this contact comes in with the confirmed case on the 8th, then you start counting it from the 8th as day 1 for 14 days onwards. Clear?
Yes.
Okay.
Okay, like I said, contacts who are quarantined and they develop symptoms during the quarantine period, the monitoring team must quickly notify the PDCO or the RRT team lead. So the RRT team will be activated to respond to the contact with now symptomatic. Okay, this is very important for RRT team. You have to respect each individual's privacy is very important. Everything that you do with the contact or the case is confidential. So data that you collected from the case investigation or from the contacts must be kept securely and not be discussed with other people outside of the RRT team. And assure people that their information will be shared with others who are involved in the response or involved in contact tracing or contact monitoring. For quarantine, basically, we keep those exposed individuals away from others so that we monitor them, especially their clinical status, if they may be, because they have been exposed to the case during that infectious period. So we need to separate them from other people and quarantine them to monitor them during that the context incubation period now, not the case incubation period, but the context. Because they have been exposed to the case, so now you have to quarantine them to monitor them during the incubation period, because within any time, within these 14 days, they may develop signs and symptoms. So in quarantine, basically you tell the contact, you will be at home. That means no movement, no unnecessary movement outside. You will be limiting contact, basically like face-to-face contact, but you can contact people using phone or other social media platform, but no physical contact. While you're at the quarantine, the contact monitoring team will monitor you daily or on alternate days, depending on each province. And during the quarantine, when you develop any signs or symptoms of COVID-19, then you will be tested. Okay, this is the line list. When you do case investigation, you collect all the contacts, and those you identified that are true contacts, they met the contact criteria, and these are the contacts that were identified during the infectious period. Then this is the line list that you enter the list of the contacts down. So you have to complete the line list for every patient under investigation. Detail of the patient under investigation or confirmed cases. The top one is for the confirmed COVID case. You list the detail of that confirmed COVID case, ID number of that confirmed case, date of symptom of onset of that confirmed case, and then the names, full name and surname, and then if he is traveling, then get the flight number, which airline he was traveling, and what seat number. This is just a sample. Then you list the context of that case. This is the line list that you use. Make sure you get what is written in the table template. Please make sure fill all these details. First name, full name, sex, age, and the relation to the contact. Is it a family member? If it's a family member, okay, be specific, wife or husband or children, or, and then date of last contact with the case, place of contact with the case, residential address for the next month, or you check the, like I said, during the interview, people change address, they move from place to place, so you have to get the address where you think that contact will stays there permanently or will stay longer than the quarantine period. So you get the address. Phone number is very important, because now with COVID-19, we don't want to go physically to access contacts daily. So phone number is very important to help the contact monitoring team to just call by phone to monitor the patient clinically on the symptoms every day or on alternate days. If the contact doesn't have a phone number, you can ask for an alternate phone number whom the contact can give, whom he or she thinks that that number is reliable, or is he can pass the message to the contact. And if there is a health facility next to where the contact is, then you also get the details of the health facility, the name of the health facility as well. Okay, here testing of contacts. You know, with the outbreak response, when a case is positive, everybody in the panic mode want to be tested. And that's how we ran out of resources, especially testing kits and all this. So now we only do testing for those who are symptomatic. So we don't test anyone who is not symptomatic or asymptomatic contact. So if the contact develops symptoms within 14 days of quarantine period, they should be tested. So if a contact is tested and the result is negative, the contact must complete their 14-day quarantine before they are released or discharged from the quarantine. If a contact is symptomatic during that quarantine period and he was swabbed and the test results comes back positive, then we follow the isolation and contact tracing procedure as usual. So we transfer him from the quarantine to the isolation facility, alert the response team, RRT team to go swab, and then they do the contact tracing, case investigation, and contact tracing continues like this. For contact follow-up, this one is when you are doing physical follow-up. So always protect yourself first before you attend to your contacts. Basic PPEs must always be adhered to. Wear your mask when you're doing contact tracing activities. Maintain social distancing when visiting contacts at least 1 meter. Do not take any physical contact, handshakes or fist bump. And do not enter the contact's house. Avoid touching anything in the contact's home or environment. Avoid touching anything in the contact's home environment. Like if you go physically to do a contact tracing, you assess if you are feeling threatened, or you assess the situation or the environment you are living in, you are visiting. If you think that you have been threatened or you don't feel secure, then you don't need to continue. You leave the area immediately and find ways to get back to that contact. So you conduct any contact tracing activities discreetly, or meaning separately. Like you don't get all the contacts together. Then, other people will see as, oh, these are the contacts of the case. So we try to, as much as possible, to reduce stigma and discrimination. So we should be like alert and how we conduct our contact tracing is very important. We need to build trust and confidentiality so that what the purpose you are there for, you achieve and you go back. So if conducting a physical visit, avoid bringing large number of staff. When more people go, it's already, the contact and other people in that area will, because these people are like this and that team is coming. So we don't want to create this atmosphere. So you only bring those who are essential, or the RRT team only, or the contact traces only to that house. And avoid interviewing the contacts in front of the public. So you maintain trust and reduce stigma and discrimination. Okay, this is a case scenario. Again, we are doing another exercise so that we really understand how to calculate the incubation period, the infectious period, and the importance of doing this. So in this case scenario here, what is Michael's infectious period? Michael, a 25-year-old male, tested positive for COVID-19 on 20th April. And he developed cough, sore throat, and runny nose on the 15th April and went to the clinic. So what's his infectious period?
Bernie, do you want to go to the next slide to show the calendar?
Calendar, yeah, sure.
Then they can see, yeah. It makes it easier.
Yeah.
Can we see the scenario first and come to the calendar?
Oh.
Okay, Michael was 25-year-old male, tested positive for, wait, this one. Test positive on the 20th April, and he was symptomatic 15th April. So you calculate the infectious period from what time to what date? And then what date during in your timeline will you start contact tracing? This is the date. Can we have some answers?
Tim. Some answers, please.
Infectious period is on the 13th April.
What was the infectious period?
It was between 13th April.
To 26. 13 to 26.
So infectious period is 2 days before. You see, are we going to, we have 2 dates here, a date of the result, test done, and date of the symptom. So with the infectious period now, which of these 2 dates are you going to calculate your infectious period starts?
Date of symptoms.
15th April.
Correct. Okay, so okay, that's the day symptoms started, but you have to go back how many days before the symptoms?
That's why we said it's 13 to 26.
Correct. 13 to 26. So in this scenario, we have the test done and the result comes out on the 20th. And he was also symptomatic on the 15th. So in here, now we will look at the symptoms, the date before the test. So we focus our infectious period on the symptoms.
Yes.
So it's 2 days before the symptom is 13. And then you count how many days?
14 days.
14 days, so?
26.
Okay. So from 13 to the 26, that's the
Infectious period.
infectious period. Good. And what do we do with this time frame here from 13 to 26?
Contact tracing.
Isolate the patient into contact tracing.
I mean, you did your contact. Yes, you are right. You will do contact tracing. So those contacts identified within that time period, from that 13 to the 26th. You do contact, you identify those contacts within this time frame and quarantine them. And you will have to quarantine them depending on when you identify them to and when they are exposed to the case. Those who are exposed to when he was symptomatic will be quarantined for that full 14 days. But there may be some who may be identified later after he was, after 20th or after 50th. Then the number of them being in quarantine may be reduced. They will not stay full 14 days. but it may be reduced based on the date that they were exposed to the case during that infectious period.
Good afternoon, Gibson. Emmanuel here.
Yes, Emmanuel.
So we have the case been diagnosed, tested positive on the 20th of April, but our infectious period goes on all the way to the 26th now. So once the case has been diagnosed, tested positive on the 20th, then the case is isolated now. So if you are looking for contacts, then your contacts should be starting from the 13th to the 20th for those symptomatics and for those non-symptomatic to be quarantined and follow up for 14 days. So just to clarify that if the patient has been diagnosed on the 20th and is isolated, then from the 20th you go back to the 13th. Within that time frame, you get those contacts for isolation, for quarantine and monitoring. Okay.
That's 7 days downstream.
Yeah. Yeah.
20.
Yeah. So it depends on the time where they tested positive and the confirmed case is isolated. If the confirmed case is not isolated, and then you will go for full 14 days to do contact tracing.
Thank you.
Is it clear or need further explanation? Because we need to get this right. We might quarantine people too long and all this, so we get this basic understanding right. So we calculate the exact number of quarantine for context based on the infectious period. So it's always the case that when the case is confirmed positive, definitely it must be isolated. Even though like we calculate the quarantine period like Manu explained from 13 to 26. But if he is isolated as soon as the result comes out on the 20th, then you move your those contacts from 13 to 20 when he was exposed before you went into isolation. Is it clear?
Yes. No.
Okay, if it's understood, then we move on. Oh, yeah.
Understood, comment.
Okay, yeah, we just explained. Yeah. Continue. Okay. At least we understand timeline and when to identify context, and quarantine is very important.
Yeah, that was clear one. Those are the clear signs and symptoms, possible signs and symptoms of COVID that appeared on testing. And then led up to the test done and that confirmed.
Sorry, I cannot hear what you say. Are you asking questions or?
No, I'm saying it's clear.
Just
It's clear.
discussion. It's clear now.
Yeah, date of onset of symptoms between that to the test that confirms. So that's what I'm saying. It's clear.
So
and
it's
that's we are right to isolate and do contact tracing. So that's what.
Yeah. Okay. Then I think we've come to the end of the discussion. Any questions or comments or opinions?
Just hello.
Hello.
Yeah. Right. Just one little bit also. I think this is very, very important because there's been quite a number of complaints in terms of isolation. We all know that isolation is done not in a not as written by the book. In some place, I know we start off asking people to isolate at home. I think in most cases that's what's been done now. We just need to make sure we estimate the time, date properly and give it to them, because it can be very frustrating to lock people up. So that is becoming an issue from the community perspective. So I know one province isolation is really difficult. People are not adhering to. So make sure the people are aware that if they do not listen to what we are telling to them, they are just expecting the disease to continue spread and this continue existence in the community. So explain to the people again is very important. If you understand this, then we are in a better position to explain to the people that we are trying to break the cycle of transmission. The isolation is basically to stop transmission. And then we got back to the normal life. So just make sure that that bit of the community part of the knowledge or survey, that they need to know and help us is to do that isolation. And then they will be actually helping us to do the, break the, transmission, the chain of transmission. And we will not continue, living with the lockdowns. So I just add that to people to be aware.
Thank you.
Just one comment here from Gilbert. Thank you so much. Thank you so much for the presentation, mate. And I think it's most of the people understand. Just one, all of us must understand the incubation period. It means already explained, but let me repeat the incubation period is the time when you're exposed to the virus or bacteria until the time you develop symptoms. So it varies from disease to disease. For COVID-19, it's 14 days. So don't think that 14 days is for every disease. No, it's for COVID-19. The other diseases have their own duration of incubation period. Just to remind you that. So each disease has different incubation period. The other thing about the contacts, we normally quarantine the first contact. Like now, if I get contact, if James has got a virus and James is my contact, then he should be quarantined. Now he has a contact. That's we encourage that person to, if he had to develop symptoms, they must go for swabbing. They don't need to be quarantined. We quarantine the first person that come in contact, just because of the situation of the quarantine space and places we have according to. That's what I understand. So quarantine the first contact. Any contact from the person with the contact, encourage him or her. If they develop symptoms, they go for testing. I hope that is clear. Thank you.
Thank you, Dr. Gilbert. In Oro, are there any more questions for Bernie, Dr. Gilbert, or Barry?
Question, comments? They're still thinking about it. Maybe they'll ask later. So that's why.
Okay, well, we have our experts here, so we can answer any questions.
I can just continue discussing some experience in some provinces that confirmed cases are actually not helping us to do the isolation part, especially those who had no symptoms, but it turned out to be positive. So, those ones are difficult to manage. They will continue to give you problems in terms of, hey, how come I don't have the symptoms and then I'm positive, so I can still go around. I think the important message here is that you can still be, you cannot develop the symptoms, but you can still spread the disease to others, to family members and especially to the vulnerable who most likely to end up dying from it. So I think the important message here is that, if they can do the simple, quarantine and also one day in quarantine to apply the, measures in terms of putting the mask if they have mask at home, or otherwise keeping a distance, and washing and the cough ethic. So it's important. So again, I refer back to, because a lot of people are probably now getting tired of the lockdown. So we can use the tiredness to tell them that it's us who's going to continue to ask the government to, lock down, because government will be concerned about 8 million people, not 1%, not 2%. You know, they'll be worried that if the disease continues to circulate in the community, it'll affect many other people. So each individual community member has got a response to play, and that's the message that we need to make them, clear that they need to help us. The government will make decisions on our attitude, on our not listening to the advice from the Department of Health or from the controller or from the government ministers. And I think understanding this incubation period and then explain to them that they need to help us to do the quarantine as well as practice the nuclear passing when they're in quarantine. Or if they do come out to get something at the shop or in the market, they need to apply the nuclear passing so that they can help us to stop the spread.
Thanks very much, Barry. Gibson, are there any questions in Oro?
Yes. Okay, Tim, come pose your questions. Hello.
Hello.
Can you hear me? Hello.
Yes, we can hear. You can ask your question.
Okay, I've got a question. It's very interesting because here in Pomdata, we don't have a testing facility out here where we get results right away. We are having results back after 2 weeks, and these are symptomatic people coming, and we are getting them tested, and specimens have been sent away to be tested, and it takes 2 weeks to come back. They are positive when the results come back, but in the 2 weeks, we don't know the status. So these people are back out to their homes, mingling around with a lot of people. So how do we curb that? Because by then, it's spreading by numbers. How do you help us curb that?
I think the answer to that is maybe Gilbert and the others can join in. I think once we get the sample from people who have the symptoms, obviously they need to be told that they need to quarantine themselves while waiting for the result to come. So that when the result comes in, they may have done the quarantine already, whether it's negative or positive. If it turns out positive, that's good news. If it turns out negative, then, well, at least we have done the test, but that's not good for the client, the patient. So I think from my understanding is that when a person comes, comes to our attention with symptoms and we did a swabbing, they need to go into quarantine. Maybe Manu can join and Gilbert can join.
In addition to that, there are also asymptomatic people who have been tested and it's turning out to be positive. They are also positive. So what happens with that?
In addition to that, I think what is referring to is those voluntary coming for test and test. And the turnaround time for oral is about 2 weeks. And while waiting for the results, these guys are, because they are they've been tested because they wanted to be tested, and now it turned out positive after 2 weeks. And while waiting for the test, these guys, because they are not unknown people, they have been voluntarily tested, and now they have been the result comes back positive. So that these guys have been running around in the community
Testings are done. Yeah, I think we need to get this clear. Testing is only done for people who got symptoms and present to us. And the contact screening, I think, it's only during the contact tracing that we identify the context, and then if it need be to get the samples. Otherwise, I think you will run out of your sampling kits and everything if you listen to the community that they just want to be screened. No, I think you need to go by the symptoms and get those who's got symptoms, and then if they become positive, then you do the contact tracing and get a sample from the contacts. And in terms of the testing there, there's a SOP for doing the testing. They're using the gene expert for those who are very ill and they need to be admitted. I think you go for gene expert. So the SOP for that has to be used. Yeah.
Okay, let me come in here, Gilbert here, to explain some of the questions. Okay, first of all, the question was asked, what happens somebody who tested positive, but he's away in the village after 14 days and then the test comes and it's positive. Now he's likely to be, spreading the virus that he's in with the people he mingled with. Now it's going to be a huge task for the RRT team, because if that person goes to the village, where he is or she is, then it's your responsibility to go and find out who are his contacts and to check with them. If his contacts are there, they should be quarantined. If they develop symptoms, you have to swab them. So this is a huge challenge because of the behavior of the person. Now you have a wider task in front of you all to try to find the cases by doing contact tracing, by following up the case of his or her contacts. And if he has the close contact, they should be quarantined. And then those, if they develop symptoms, you do the swabbing. And this is the unfortunate thing: when people go out in the community, they're exposed already to the rest of the people there and make your job twice harder. Unless, as said earlier, if the person is advised to self-quarantine or isolate themselves until the results become, then you make your job much easier. So if there's somebody also who is also asymptomatic and test positive, the same principle applies. Then you have to do contact tracing for his contact. So I think it's an excellent question. Again, the onus is on us for us to explain to the people that we do the testing. So make our job much easier later on, that we don't have to go to a wider community looking for cases at least, and we know that they're likely to infect others. I hope I explained that out.
Thank you so much. There is also another question. We have been faced up.
Please speak up. I can't hear you. Sorry.
We have been faced up with a situation here that I would like you guys to come in and assist, or even let us know how we should be going about. We have a situation where when the results come out, we don't have incident manager around, and we don't have the controller who supposed to be calling the confirmed cases to notify them that they should be isolated and they should be at homes waiting for the contact tracing team to come around. But that is not happening. And how do we move around to tell these people? They wouldn't be listening to us. So how do you advise us? Should we also be given an authority to go and tell these people and talk to them? Or should we wait for the incident manager or the controller? And in doing so, while we are waiting around, people are moving around. How do you best advise us on that?
Hello, Benedict here. I think from the NCCN, maybe Dr. Gilbert can also add in. that's from the surveillance at NCC. Normally, the positive results from CPHL is sent to the province through the focal person, and from there, the result has to be disseminated out from the province to the case that was confirmed positive. So you have to have a reporting structure and flow of information so that when the results get back to you, it has to be disseminated down to the person that was swabbed. And just to add on regarding the contact tracing and testing, like we've already mentioned, here for contact tracing and those who are asymptomatic, please don't do any testing even though they request. One, because they may be still within the infectious incubation period and the viral load may be very low and the test may not pick it up and you may have a negative result. And it's a waste of resource. And then when they become symptomatic and then you do the test, they become positive. And then the patient will question, oh, I did the test and the result was negative. And now it's positive. So please, the new SOPs will come out, no testing for any asymptomatic context. Even though they request, you do not do the test. Don't waste your resources and materials. If you start doing testing for all the contexts that are asymptomatic requesting for tests, do you have the manpower to monitor them? Do you have the resources to monitor them? Don't do that. We will waste resources. Okay, so go back. Yeah, Gilbert can head in.
Just to answer your question, I'm sorry, I don't know how to answer it, but responsibility comes down to the administrator and the people in the province to provide the support to you because you are there, you are handicapped, you don't have resources, you don't have staff, and the situations like that should come down from the high up, from the administrator and from the PHA to provide that support to you. I know you are struggling, a few people, things like that is a normal thing, not only you, but many other provinces experience the same thing you are experiencing as well. So definitely you need support from the higher level. With the police or things to go to escort you. Sometimes there is a bit of we have a situation in East Sepik where the people want to fight contact tracing people who will go there because they don't want to be interviewed or to be swabbed. So those things do happen. So you need the support from the administrator, PHA, and also from the police to help you with your work. I'm sorry to end you, and this is what the best answer I could give you to you.
No, I support Dr. Gilbert's point that I think as we learned yesterday about the different levels of communication, communicating up, communicating across, and communicating down. I think you will have a lot of challenges communicating down, but I think that's when you kind of reach out to the authority to kind of get your support. So it's important to know that there's always kind of help there. Even if there is no help coming from the provincial level, it's good to reach out to Barry or somebody at the emergency control center at the national level. So always, it's important to kind of communicate.
Okay, if I may add, I think two things. One is when the result comes in. This is in fact, the responsibility of the surveillance unit, like in NCC, and also at the National Department of Health level. NCC and COVID came around, it's only one disease we're dealing with. Otherwise, it's a function of the surveillance unit. And in the province, you don't have a surveillance unit, but you have only one PDCO. And, when we disperse the funds, the province made a plan on how the funds are supposed to be used. And in that plan, they were also mentioned of hiring additional people. And I think keeping track of records and making sure that when the result comes and giving the result back to the patients, is so important because they need to know the results so that they can help us to know that they have to still continue the quarantine period, or otherwise refer the relatives if they develop symptoms or not. So it comes down to management, and I think in terms of making the POC function at the province level, you have to have a health sector incident management system working. At the provincial level, you have to have the whole sector committee, which all provinces have. And I know that Oro province is one province where we have been having a lot of problem over time and again, the instability of the CEO position, and you still seem to have that problem at the moment. So I think the key person that need to ensure that in terms of surveillance, sample collection, and getting the results to your end and giving the results back to the patients as and when the results become available, really is the responsibility of the disease control officer and his assistant, if there's one. If there's no one, then I think it's this team that decide and then talk to the incident manager and the CEO that we need people, if outside of the health system on a temporary basis or even volunteers to assist in terms of record keeping and this, giving information out. So that you need to discuss among yourself. I think this is one of the problems that now through this training and the discussion, we identified that this is a key area that need to be, solved in terms of keeping track of the results coming and then giving the results back to the patients. So really, it's this team, it's this rapid response team that you need to prioritize, where you need additional people, where you need additional resources. And like Abel said, we are here at the national level if there are any questions, you can reach out to us. The COVID team is at the NCC, surveillance leads are in NCC for COVID. Logistics team, there's a lead person with a team of assistants and people helping there. And in terms of communication as well. So I think you're a special case. People know about Oro. Oro is, there has been over time management issue in terms of stabilizing that province with the permanent appointment of CEO and the CEO staying there longer to see that whatever the plan and aspirations of PHA is, seen to work in terms of health delivery in that province. So I think you are not you're not up there where easily can be kicked around. I mean, like for myself, I enjoy the privilege of being a technical person in the Department of Health. Only the SCM and the 2 deputy secretaries and secretary are kicked around by the top politicians because I keep silent and do my job. Because I know what I'm supposed to do. The top manager is not my business. So if we can do what we are tasked to do, even though the top is not there, and then leave alone the politics of the politics. And then I think we can show them that this is how much we can do with our resource and your support. This is how much we have done, and show them the results and show them the gaps that they're supposed to fill in, but they did not do their part. I think we can start somewhere out there. Does it make any sense?
Thank you. Yeah.
But don't worry, I think we will have someday a good CEO, a permanent CEO, and hopefully, the book says that the last shall be first too. So sometime along the line, the Oro might stand up, come first. So we just keep on praying and hanging there, and let's hope that this administrative blockage or sort of issue that we have, we continue to have to be solved at one point.
Yes, thank you for that. Thank you for that encouragement.
Finally, don't stop. We are now starting you off with a fire, and in a few weeks' time, we are trying to make a physical visit to you after this video training. In a few weeks' time, to make sure that we come and see that you are meeting, you are discussing, and continue to meet and document your meetings, and then move it up to the Director of Public Health and also all the directors there, whoever is acting, and also whoever is in CEO there, give it to your provincial PHA, provincial administrator, who's supposed to be the chair of the provincial task force. And if it need be, post it through the, have it through the, the email trace that's coming through to sharing the national, updates that's coming to you, so that your team must be seen function. Let's forget about the top one. Minute your discussions, minute your problems, issues, put your recommendations down, and then give it to the top brass and also to the provincial administrator if he's the chairman of the provincial task force. And then I encourage you to send it to the incident manager directly, because incident manager responsibility is to share with the rest of the team members. If you send it to the incident manager, that's good enough. I'm not saying that you have to do it, because I don't want you to be sacked tomorrow and then I will not Jeff to give it to you. But if you see that's okay to you. Thank you.
Thank you. Thank you. We will continue to.
But otherwise, you can do the other way around. I tell people, you let me know, you let other people in the department know, and then we'll make noise in various meetings and that we have in the department as well as in NCC on your behalf.
Thank you. Thank you.
Thank you, Barry. Any more questions, Gibson, from the room?
Anybody else? Some questions. Everybody seems to be quiet. But generally, this training is very, very good, and we really appreciate what's happening. Thank you for choosing Oro to be the first one.
No problem. We're really glad to meet you all and do this training. We're learning a lot as well about what you're experiencing. So we have got 2 topics left. If you want, we can cover these. It would take about 20 minutes. One is sample collection, which we think is important, and the situation report, how to write the report on the response to give back to your PHA, communicating up, like Abel said. And then we have just a conclusion and the next steps. So if you're happy, we can keep going. Do you want to have a stretch? You can have a stretch in the room if you need.
Yes.
But I can get started and just do the sample collection.
Let's quiet.
No worries, Abel. Thanks a lot. Okay, so this session is about sample collection and packaging. In the second half, I'm going to focus on collecting specimens for COVID-19 testing and the proper packaging and labeling and transport of these. But also at the end of this session, you'll be able to describe the role of the laboratory generally in the RRT and know how to look up the priority specimens to be collected based on the information available, and to use your laboratory team member as the expert in this as well. So when preparing for an outbreak investigation, the RRT has the duty of contacting the lab to discuss the sample collection, storage, and transport, so they know that what they're planning is correct. They should also inform the laboratory staff when to expect the specimens to arrive for testing and to follow up on the shipment of those specimens until they get to the right person. So in Papua New Guinea, there's 10 syndromic surveillance and pathogen alerts. They're all listed here. We won't go into them, but I guess if you needed to investigate any events reported of diarrhea or acute flaccid paralysis or unknown fever, would you know where to find the information on what specimens to collect and how to collect them? And I know you do have a laboratory expert on the team. I wanted to check if you have access to the yellow outbreak manual for Papua New Guinea. You do?
We do have, yes.
You have this, can you see this book in my video? So this is a great book. It has all the different syndromes and the specimens to collect and the time frames and everything. And I know that your lab team member is a great resource, but you can also check this manual if you want some idea of which specimens that you need to collect. I won't go into all of them, but the manual is it's terrific in just figuring out what is the best specimens. And there is a summary table, I think, in the manual, just here, saying what sample, from who, how much, the container to use, the storage and the transport. So sorry it's quite quick, but we wanted to cover generally about sample collection and where you can go to find the information to see which samples you should collect. What is important for the whole team, and I did want to ask if you could suggest some answers to this question. Why might samples be rejected by the laboratory if you sent them? It's an important issue. We know it does happen a lot in Papua New Guinea. So why do you think samples might get rejected?
The samples have not been collected in the way it's supposed to be. Wrong labels or samples have been not been done correctly.
Sorry, my audio is not great. Did you say that they're not labeled?
Labels done not being correctly labeled on the sample specimen bottles or specimen containers. And
Yeah.
that's one. The second one is if the samples have been not done properly.
Yes, sample wasn't collected correctly. Yep. Any other reason?
The use of wrong specimen containers for the specimen.
Yep.
Sometimes less than the required number of specimen that is required for the specific testing.
Yep. That's great. You've covered everything. The other reason might be that the sample has leaked or the container's broken. So yeah, just to highlight to take care when collecting and the way that you package the specimen is important to prevent leaks or breakage. Terrific. So key messages is just that the sample collection and the time and the processing directly affect the quality and the reliability of testing results. So do need to be very careful about taking care for collection and the time. Rapid delivery of the sample to the lab is important as well. And always think about the types and the numbers of samples required and the proper labeling. Most of all, discuss your plans with the laboratory. That way you can check that you're doing the right thing. You can give them the heads up that the samples are coming and they know that to expect them, and record all your steps and just keep informed with the lab. Okay, we'll move on to COVID-19. I just want to say that all these slides were provided by Leonie at WHO. She's our lab expert, so a special thank you to her.
Sorry, Catherine, just wanted to add something.
Oh, sure.
One of the reasons why samples are discarded, also like with the experience with COVID-19, some are sending samples without the CIF form, the form to accompany the samples. So the samples are discarded because of no form attached.
Very good point. Thanks, Bernie. And I think Dr. Gilbert, sorry, my chat's not working. Dr. Gilbert pointed out samples have been rejected because full of betel nut and lime, so contamination as well. Yep, very important. We go to all that work to get the samples and you don't complete the form or you have the contamination. It's a shame. Okay. So COVID-19. So during the outbreak, it's important to detect as many cases as possible. The best way to detect cases and ensure that they are investigated is first, obtain complete patient information on the case investigation form, which is what Bernie just said, and obtain the good quality sample. So we'll take a closer look at the methods for collecting COVID-19 lab samples. And the main method used is with a swab. When we use swabs to take samples for diagnosis, the goal is to scrape off some skin or fluid that has the potential bacteria or virus or other bug onto the swab. And then that swab can be tested in the lab. The general principle for taking the diagnostic swabs remains the same when testing for COVID-19. We know that the cells that have the coronavirus are located at the back of the throat, seen here with the arrow. So the aim is to use the swab to scrape some of those cells onto a swab that can be sent to a laboratory. And there are two ways of reaching the back of the throat with the swab. One is through the nose, the nasopharyngeal method. The other is through the mouth, the oropharyngeal. And when we talk about swabs, there are different types that can be used. For the nasopharyngeal swab, there's this dacron or flocked. It's a bit thinner, the flocked swab. And then the oropharyngeal swab is a bit bigger. We try not to use oropharyngeal. We prioritize nasal. But if you're unsuccessful in attempting to get the nasopharyngeal swab, or if you don't have those thinner special nasopharyngeal swabs available, then the oropharyngeal method can be used. There are really important swabbing don'ts to remember. So do not use the big oropharyngeal swab to collect a nasopharyngeal sample. It's really big. It won't be able to get the quality sample you want far up the nose, and it's really painful for the person. So we don't use those big swabs. We also don't push swabs too hard up the nose because this can be really traumatic, especially the younger patients. So as we said, if we attempt and we just can't get that nasopharyngeal swab, we try oral instead. We also don't use calcium alginate swabs or swabs that have a wooden shaft there. These can contain substances that inactivate the virus and inhibit the genetic PCR test that needs to be done. After the swab is collected, it is inserted into universal transport medium, or UTM. And this is a liquid that keeps the collected virus intact. Other equipment that is needed, just in case, includes tongue depressors and a tissue for the patient to blow and wipe their nose. Also, never leave for the field without a biohazard bag for disposable of all the non-sharp materials. And all of your equipment for specimen storage if needed. It's really important to keep the samples cool if they're going to be sent for the genetic PCR testing. If the virus gets heated above 8 degrees Celsius, then the whole structure of the genes is affected and the PCR test can't detect the virus. So aside from this esky or cooler and ice packs to keep the sample cool, don't forget specimen bags as well. This is a basic requirement in case any infectious material spills from the tube, if the tube leaks. So the lab always requires this bag. And last but not least, you need all of your PPE, which we talked about this morning. This is to practice the high standard of infection control. And in your manual, we have got a checklist for the laboratory. actually for all the RRT roles. And you might want to go through and add any items you think we've missed, but it's just to help you when you're getting ready to make sure you've got all the items you'll need. So any clinicians in the room will know this procedure, but we know that RRT might be out collecting samples and helping the clinicians. So we thought we should walk through the methods of collecting the swabs, and you can let us know if you're happy to go through this sort of training. Here are the 4 steps to prepare for the sample collection. First, so important, fill out the case investigation form and completely. We need as much detail as possible in case the person is infected. Second, check that the tube label is filled out and matches what's on the case investigation form, especially the name and the date of birth, that minimal information the lab needs. Third, place the form into the pocket provided on the outside of the specimen bag. And now you can go and take the specimen, but make sure you've got all of your clean procedures taken care of. Remember that any single one of the people you are swabbing could be infected. So it's important you protect yourself and maintain strict infection control so you don't contaminate any other surfaces and maybe cause infection in others. So you don your PPE, your gloves, gown, respirator, eye protection. Remember, if you are taking a sample, it needs to be a respirator and to check the seal. You sit the patient down and ask them to blow their nose and that they discard this safely in a bin. Next, open the sterile flocked swab and ask the patient to tilt their head back and gently insert this swab into the nostril and back until there's just a slight bit of resistance. And the thing with the nasopharyngeal, it does have to be far up enough that you do get a bit of resistance. If you don't go far up enough, you might miss the cells that we know are further up towards the back of the throat or the back of the nose. Rotate the swab 2 or 3 times and hold in place for 2 to 3 seconds, and then slowly take the swab out. This is a really critical part. Without touching the swab at all, place the swab into that UTM tube, universal transport media, and break off at the break point line that you can see on the swab. Don't try and break above that line because then the swab shaft is too long and you can't close the lid on the tube. And sometimes it happens that you break above, you still try and close the tube, it's not tight and it does leak. Then place the tube in the Ziploc bag and seal it, and there should be a case investigation form with that tube. And we covered the donning and doffing this morning. This is the glove-in-glove method again. Always change gloves after taking one patient's swab, and always use hand hygiene. Sometimes you might need to take the oropharyngeal swab. The steps are very similar. The main differences are when preparing the patient and the swab that you use to collect the cells. So instead of asking them to blow their nose, you ask them to rinse out their mouth with water. And this is to make sure no food contaminants are going to affect the swab. Importantly, there's betel nut. This is known to affect viral stability and testing, as Dr. Gilbert said. When taking the oropharyngeal swab, you'll need a tongue depressor to help. So you ask the patient to tilt their head back, open their mouth wide, and they need to say ah, so you can see the tonsils. And there, this gives the best chance to swab each tonsil and the posterior pharynx. They're shown here with the stars on this photo. Avoid swabbing any of the gums or the teeth or the tongue. You want the cells that might have coronavirus at the back. And finally, we'll cover the proper transport and packing of the specimens. This can be applied to other non-COVID samples too. We know packing and transport is very, very important, but always check with the lab to make sure that you're doing it the right way or how they prefer. So firstly, we make sure to use the International Air Transport Associated / WHO certified shipper. And these certified shippers have received a qualification that lets them ship dangerous goods in accordance with international law. As we mentioned earlier, for the PCR test for coronavirus, the specimens need to be kept cool. They need to be between 2 to 8 degrees, definitely not above 8 degrees Celsius, or we risk the test becoming a false negative. Ideally, the specimen should be shipped to the lab within 48 hours of the sample being collected, and definitely no later than 3 days, 72 hours. You can arrange to ship with a TNT courier. You can use a WHO account or via road if possible. For storing the specimens, this depends on the time it will take for you to be able to send them to the lab. If the specimen will be tested or transported within 72 hours, you can store it at 2 to 8 degrees, so in the fridge. If the transport will take longer than 72 hours, then it really should be stored at -70. And this is really hard to do, and in this case, we need to consult with provincial labs for assistance. So the take-home message for this lab testing is that the test result will only be as good as the sample collection, storage, and shipping. I would say also the completeness of the information accompanying the sample. A bad quality sample can give an unreliable result and have high consequences, especially if it's a false negative. So we'll provide lots of references and resources on the Google Classrooms and when we send all of these slides for you. And we can always refer you to the lab experts like Leonie at WHO. I did just want to ask for a few minutes, how is your COVID-19 sampling going in Oro? Have you been out there sampling for COVID-19, and what methods have you been using?
I'm going to respond to this one. Okay, one of our lab scientists will respond.
Sure.
So far, so good. We are also doing antigen testing for COVID-19. Yeah.
You're doing the rapid antigen testing?
Yes, apart from sample collection for PCR.
Okay. And who is doing that in the field? You and anyone else in the RRT?
Another medical laboratory scientist too. Both of us are going ahead in conducting this RRT testing and sample collection.
Great.
Out in the field.
Are you mostly using the rapid detection test?
Only for symptomatic clients and patients who are symptomatic for less than 7 days. We are doing RRTs, and for the others, we are doing sample collection for PCR.
Mm-hmm. Terrific. Okay. And any comments on the turnaround time for PCR testing or any difficulties you're facing in the field with testing?
The swabbing part is okay because we are up to date with it, but it's the turnaround time for our results that's posing a problem for us because we received the results after 2 weeks. Yeah. Yes.
Yeah.
That is a very big issue here. But otherwise, we are coming up and we are okay now. After this training, I believe we will have a strong team to go out and do our surveillance too. Thank you.
Sorry, just intervention here, Kelpet here. For antigen PCR test, I think there's a new instructions. I already received it or it's going out that once a person is test positive, is positive. You don't need to collect repeat sample for PCR testing.
Yes,
I
we
think
are
that's
collecting
this.
sample. Yep.
Yeah,
But
you
in,
don't need to do that.
RRT, one for PCR for confirmation.
I think you, as I was saying, there is no need to collect any more sample for confirmation. Once a positive is positive. I think they're aware of the delay in the returning results and turnover time. So I don't know, you already got instruction already from the team from the, or not yet, but that's what I was informed.
Okay, thank you for that information.
Just posted, but maybe the tip didn't inform you guys of that change that is about the controls.
Gilbert and surveillance team at NCC. I think that Emmanuel is confirming that here, but I think that message is not clear out in the public because this will have a lot of impact on numbers that we'll be dealing with. And my question and also those others will have is that what is the reliability? What is the sensitivity and sensitivity of this test kit? Because once we confirm this, then we need to take the measures into account of isolation, meaning that they will, tend to, isolate themselves and they will forego the normal day-to-day work. So I think this is the first time I'm hearing, to tell the truth, and I think we need to make sure that goes out in a big way, the media and from the controller, because it will affect the people. People already know that the RRT is only for to determine whether the person has come in contact with any kind of virus or germ, whatever, and it doesn't necessarily mean that it's currently infectious or it's a current infection. So I think that need to be. I think if it is a test edition, it just need to be widely, communicated to the public, including the whole 8 million people, not just the health workers, because the affected people, people need to know that if the RRT is positive, then they need to go for quarantine.
Yeah, Perry, that's what I was told. So probably you're right. We could get the people from NCC to use that instruction.
Yeah, take it back to the meeting.
The sensitivity is almost 100. That's a true positive, but on the specificity is a bit lower. That's why they use that as a means. But again, the antigen RTG test is now in rollout, and the whole country is doing that because of the. Yeah. We're running out of gene expert cartridges, which is globally not only PNG. Yeah. So you have to be very careful to use it on the criteria that's set only for those with SARI. You use that, and then otherwise, and then for PCR, is turnaround time is quite longer. That's why we try to reduce the cut-down time so you have also the sub intervene. So my suggestion is, Perry, you're right. I think we need to get instruction from the team. I think whether the information already gone out or not, I'm not sure, but that's what I get it. So I'm releasing to Oro. So just Oro, keep doing what you've been doing. Once we get clear instruction from the NCC team out.
So Oro team, we clear out.
Yes.
Okay.
Great, thanks very much. I just had one more question for your lab expert. Did you get training on the RDT? Do you think we should include, we do not have the RDT training. Should we include that in the rapid response team training?
Yes, we had one training, but I'd like another one again for our RDT team.
Okay, thanks very much. Any other comments on how testing is going? Any issues you're experiencing in the field?
Yes,
Gibson, good afternoon, and Tim. It's Emmanuel here.
Yes, Iman. Go ahead.
Okay, I just want to know the supply, the stock of the AGRDT that kit you have in your province? Do you have enough? How many do you have? And how many have you used for testing already?
The RRT for. We actually have 400 issues, and I have no idea. So we were almost tested about 150. You see now the RRT, and then we have enough kits for other testing.
Okay, thank you. It's the RRT. Is the RRT response out in the province doing SGRDT for cases out of the facilities, or just the SGRDT is used at the hospitals and health facilities only?
We are using it outside on contact. On contacts, they are using it also on contact tracing.
Okay. Thank you. Thank you. Yeah. Only for symptomatic. Is that right?
Yes. Yes.
Thank you. Thank you.
Even for contacts too, only on symptomatic.
That's right. That's right. Yeah.
So certainly, I think we may require one more training now.
Yes, please.
Go through the process again, and maybe we will put this one up with the NCC team to revisit that, and maybe find one time and do that immediately.
That sounds great.
I have another. Hello.
Yes.
I have another comment to make in terms of the laboratory. Currently, our lab is very small. Last year and then this year we were doing some clinical tests, but all those tests were negative. And then after the next wave came about, and because of the space there, we decided not to do any testing. Okay, at the moment we have a company who is willing to give us a small mobile, or I would say small lab. They've actually already found 2 containers, and they're trying to do that. I don't know. It's not really. They're not progressing well, and that's why most of our testing is done with the RRT plus sending the samples to CPHL via to overseas labs. Okay, I have a question here. In terms of because I heard from some officers from CPHL, in terms of those cases that are positive, after 14 days, we don't need to collect any sample. Is that correct?
That's correct. That's correct. You don't have to.
Thank you.
Even for RRT and also PCR and gene expect, after 14 days, if they've done the quarantine, we don't have to collect another second sample to prove them they are negative or they're still positive. So they will, in RRT will be still positive because it will show exposure as well. But they will not be, infectious to be able to transmit the disease.
Thanks, Barry. Any more questions or comments from the team?
Just addition to this construction, make sure if anything to do with lab, and make sure keep in touch with the CPHL, because they have certain requirements in order for them to build labs, and also even whether it's a mobile or because if they don't meet those requirements, they will not approve the installation of the machine and use of that lab. At the same time, it must be in accordance to the standards set by the health department, and somebody need to check that with our health facilities branch to ensure it meets our standards. Because some people may be walking away with money.
Yes, prior to doing the design, we consulted the CPHA and they do the design and make some changes, and then now it's going to be with a private company to go ahead.
If the lab person is dead, raise the matter with the Director for Public Health. I think Willie Parao is acting Director of Public Health in the absence of who's this doctor? Yeah, and Jan Lin is the lab manager. So just raise with them so that then they will know what's happened there and they can communicate with the appropriate people to ensure that they build a high quality and meeting the standards. So in terms of using the, I think, rapid diagnosis test, and in the absence of your PCR or gene expect machine, I think you need to really sort of use the RRT test for symptomatic patients, so you don't run out of the test kits, and then apply the quarantine period. Estimate the period of the quarantine using the onset of symptom and the time of the testing. And then probably I don't want to make the decision here because I'm not in NCC, but I think the Harris Gilbert is here there, and Manu is here, and Ben is here, so we'll let them take it up quickly so that the information or direction or order need to be, swiftly and need to be taken out to the provinces as soon as possible.
Okay, thanks everyone. We might move on to our last topic. It will be very quick. I know it's getting to 4:30, but we thought it's important to cover this, which is the situation report. So we'll cover the basic components. There's many different reports that can be produced during the outbreak or emergency response, and this daily situation report is very important. So it's important for communicating up during the RRT. Abel covered a lot of the communication plan yesterday. It's also vital to help the team keep track of how the outbreak and their public health interventions are progressing. And the report can be used to guide decision-making and request resources and guide the risk communications out to the community. It's going to be the go-to document for the response as well. There can be pressure to produce this report quickly and make sure it's accurate. And it is a document that is kept internally, so it's not designed for public release for everyone to read. The format of this situation report varies. This is just a suggestion of some of the sections that you can include, and we'll review each section. But you might tailor the report for your team and what you think you need to include based on the response you're on. So the background of the report provides context and helps the reader understand how the event has developed. It's important to include details on when the first case or the first event occurred, and then when the investigations started, and then any other key dates. And a summary of the situation provides an overview of the situation assessment or the risk assessment, which we talked about yesterday. Laura covered this topic. It's one of the most important parts because people who are busy will probably only read this section. And here's where you can include an overview of what has been done, what is planned, and what is needed for the response. You can include the key stakeholders that are part of your outbreak, clearly highlighting their role and their contact details. And this highlights who on the team has engaged or has been engaged with during the response. It provides a central place for recording the contact information that you might need or your supervisor might need in a hurry. You might include the case definitions. This is really helpful for any rapid response when you're investigating an outbreak to keep you on track with what you're investigating. Remember, the case definitions includes the clinical or laboratory diagnosis, the person, place, and time. You can include your activities on active case finding, case and close contact follow-up in another section. So this provides a summary of what's been done to go and identify more cases and how contacts are being traced and investigated. Here you can also describe community engagement activities and other efforts that you're using to identify any cases or contacts. There's usually always a data section to a situation report, and this is kind of the meat of the report. It's a summary of the epidemiologic information, and usually it will be the surveillance officer and the field epidemiologist that will have this data and will lead the development of this section of the report. Typically, we always summarize the person, place, and time information. So we usually have the number of cases, the number of deaths, the age, the gender, any new cases, important information like that. Often you'll include also the famous epidemic curve. This is a staple inclusion on any situation report focused on investigating an infectious disease. As Laura touched on yesterday, an epidemic curve provides a lot of information about how an outbreak is going. The number of cases over time can show, is the outbreak increasing, decreasing, things like that. It's important to include a summary of how severe the situation is as well. How serious is the risk? So indicators include how many people are in hospital, how many are in intensive care, and how many have died. Depending on the situation, you might want to include number of hospital beds available and other important information to indicate if you need more resources quickly. And then a final section to think about is a summary of the control measures that have been implemented. And it's a good idea to list these any of the key interventions by date. It helps you track on how effective the response is going. And especially once you get to the end of a response or the end of a deployment, you can have a look at this information and determine if the right interventions were taken at the right time. So very quick run through of what you can include in a situation report. You can check your manual where Tambri has written an example of a very comprehensive outbreak report, including data, epidemic curve, all of that you can refer to. Don't underestimate how long a report takes to put together. It is something that feels like a task, but with a team, you can work together, get the information all in one place and report that information up to your leadership. It really is an important part of an outbreak investigation. The key thing to remember is that this situation report allows evidence-based decision-making. So you can see how effective your response is going and that you are taking the right courses of action. Were there any questions about situation report? Have you been writing any of these as a RRT? Or submitting these as part of the COVID-19 response? Was that someone in Oro commenting? I couldn't quite tell.
Sorry, our mute was not, we're not muted, so we were just discussing.
Oh, sure, sorry.
We found out that our mute is not on, so I came to mute ourselves.
Thanks, Barry.
But I was trying to point out that the national level surveillance report that goes out to the incident managers and within the health sector is actually following the same structure of the report. So if the province doesn't have one, I'm sure some of the members of the province may be receiving that report. They just need to change the title as like for provincial level reporting and use the same format.
I'll just add, I think Barry will be in Oro in a couple of weeks' time. So maybe a challenge for Oro province is to have a sit rep ready for when we come. Can be based on the national one. It can be based on the guideline in the outbreak in the RRT manual that you have. But it's good to start getting an Excel database together to record all the suspected cases, all the confirmed cases, the date of the onset of your confirmed cases. And we can help you when we get there if you're struggling with putting a sit rep together or doing the analysis. But this would be a good thing to commence, and it should be done either daily or weekly. The national one's done every day. Depends how much activity there is in your province. If there's new data coming in every day, it should be produced every day, summarize that data. It doesn't have to be a big, long sit rep. It can be even 1 or 2 pages to start with. And then you just update. You don't rewrite it every day, you just update the numbers every day. And yeah, add in extra details. And this sit rep will be forwarded up. It's primarily a document that goes up, the communication up to your senior management. It will be the document that will guide all the public communications that will come out of Oro. This will be the main reference document for your response.
I think that's a good idea. We will start working on it after this training, doing our own sit rep, so we can inform our people here of what's happening here. I think I wasn't thinking of that, and kind of like, yeah. Thank you, James. I'll start working on this within the weekend. When your team visits me, then you guys can help me out in any part where I will be struggling.
Yeah, I think you are coming good already on the email. So if you can share any drafts with us, then we can just help out. Then before you even send out, and make sure you share with your team members that now that you are in training, you as a team, so that other section can make the input in, like the lab can, whoever's taking charge of the RRT test can give a sort of rundown on number of tests been done, what stock levels there, and that type of thing. So it doesn't have to be very detailed, but you can start somewhere.
Good.
I think that's probably also a better way, because I've seen some provinces where the top management is not seen to be working in terms of convening regular meetings and regular updates. That your level of team seem to take the attention when they circulate their work report up to them, and also CC to some of us at the national level and the national incident manager. It does take the attention once you start doing that way.
Yes, thank you.
Gibson, how complete are the case information forms that are being filled in your province? Have they been filled in quite well? Because this is where you'll get all your information to develop a simple Excel database. And you have things like the date of onset of the case, if they're male and female, their age, and things like that. So good to review the case investigation form, just make sure they're well completed with all that key epi information, because from that we'll create the database, and then from that you'll create your SITREP.
Yeah, thanks, Papi.
Okay, we might move to our conclusion for the training. I'd like to invite Dr. Laura. You might remember that she presented yesterday on outbreak investigation steps at the very start of the training. She's just going to present once more a summary of the outbreak investigation. We didn't cover everything we had planned in the training because we had so much wonderful discussion, but I think this will be a nice closeout for the 2 days of training we've had. Laura, please go ahead.
Great. Thank you very much, Joe. And great to be closing off with everybody today. Can you see my presentation on the screen?
Yep, just the slide. Thanks.
Perfect. You can still see the slide?
Yes.
Yep. Perfect. So just a very, very quick recap of what we have covered during these 2 days. I know it's a lot of content, but there are some key things that I hope you can remember. Firstly, an outbreak is a higher than expected number of cases with the same disease or similar symptoms. So to know if we have a higher than expected number of cases, we need to know what the baseline is, and we need to know how many cases we currently have. Outbreaks start when you find something unusual or unexpected. Outbreak investigations, and you can't be expected to investigate every unusual thing that comes across your desk. So you must be able to triage the information to identify signals which are possible outbreaks or events. When you investigate outbreaks, you want to answer these 3 questions. Is there an outbreak? And if so, what is the cause? 2, what are the factors contributing to the outbreak? And 3, what priority actions can we take? And you answer these questions using a systematic approach so you don't miss anything. In PNG, that's an 8-step approach, but you will usually complete these steps in a different order, and you will usually complete multiple steps at the same time. That's okay. So the first step is the first question that we want to ask, is there an outbreak? And if so, what is the cause? We do that through confirming the outbreak. So we have the signal and we go through a verification process. From the verification process, we can either determine that it was a false alarm or that we have a genuine event. We try and establish the diagnosis as well. Sometimes you'll have this information straight away, but sometimes it will come a little bit later, and that's okay too. Risk assessment can help you prioritize which events you need to respond to. That is where there is a risk to human health. So during the risk assessment process, you will collect information and you will assess the situation. You will make an exposure assessment and you'll assess the context. You will decide an overall level of risk from low to very high. And based on the level of risk, you will decide how you will respond. And as Barry said yesterday, that response could be as simple as ringing people up and providing some advice over the phone, or it could be more complex. You could deploy to the community that is impacted. The second question, what factors are contributing to the outbreak? By answering question 2, what factors are contributing to the outbreak? We do this through a series of steps. We develop a case definition. We find cases through this case definition and through contact tracing. We collect information, we document it, and then we describe and interpret the data. To complete these steps, we need a team with all sorts of skills, and that's why you're all here today, because you all bring different skills to the outbreak investigation. So we need skills to interview, we need skills to communicate, we need data analytics skills, skills in infection control and prevention, and many other different skills, specimen collection. That's why you're working together as a team and you come from all different backgrounds. The last question, what priority actions can you take? People often forget this, but it's the most important thing. You want to reduce the risk of more people becoming infected, and you want to try and end the outbreak if you can. So this can be started right at the start, and it should continue until the outbreak is over. Implement the control measures early. You can refine these as you go, and make sure that you communicate with all of the people who need to know. And that's really engaging with the community and really having a two-way conversation. So when you're investigating outbreaks, you want to answer these 3 questions. Is there an outbreak? And if so, what is the cause? 2, what are the factors contributing to the outbreak? And 3, what priority actions can you take? And you answer these questions by following the 8 steps to outbreak investigation. We have included a pocket guide in your training package, so you can keep this in your wallet when you go out to the investigation, and it can remind you of all of the steps and how to conduct them. Are there any questions? Final questions, final comments?
Final one from me is that I think that Gibson's aware, but there's a general guideline. This is a PNG one. It's not just for COVID, but for all, outbreaks. The outbreak manual. It does provide some platform, and how to go about outbreak investigation for routine surveillance. So you can make reference to that. Maybe if you don't have a copy, we just keep it at your top of mind so that when we come a couple of weeks down the line, we can print some copies for your team members there.
Yeah, we have enough copies. Thank you.
Okay. All right.
Before we go, I just wanted to share a website with you. I'll just show it to you if I can get it up. And who in Oro has done the field epi training program?
Gibson?
Roger and Michael Shindawati.
And Michael, cool. So those who have done the field epi training program will remember we did some work in Excel, and we used Excel to generate a line list and to do an epi curve. But some of you may have forgotten a little bit how to do it. So we've got an online training tool as a refresher. If you're interested, let me just share my screen and you can actually see it. And maybe Joe can share the actual URL in the chat. but this is what it's called, fieldepinaction.com. And if you look up the top, you'll see e-learning. And if you, yeah, we can put the link in the WhatsApp group. Oh, that was the other thing we're going to do, is create an oral RRT WhatsApp group. Is that something you can arrange, Gibson? Get everyone on a WhatsApp group on your RRT? If you can create a WhatsApp and include Barry, include everyone here, that would be great. Or maybe we should create it and then we can add the other provinces as we go.
We should have a national RRT.
Yeah.
We have a national RRT.
So we'll do a national RRT group actually, and then we can share with each other.
Okay,
But this is
I just say RRT, young PNG.
Oh, yeah, great, Barry. Perfect. So the one Barry's created is.
yeah, Barry's got one created, so we'll add everyone to it.
Yeah.
So on this web page, if you go to the Excel, you can click on this course, and it will take you through a refresher on a lot of the stuff we covered. So this is what it will cover: creating a file, creating a line list, entering data and cleaning a line list, creating a data dictionary, using formulas, creating charts, etc. So that's yes. So if we go to the first one, so this is for anyone, but especially for the field epidemiologists to get a refresher. And this is what it will look like. It will have a little bit of a context, a background, and you click through it and it will ask you to download some files and practice doing different things. So it's kind of interactive. It will have some quizzes as you go through. No one's monitoring this, so you can just practice. If you get things wrong, just retry. And it's a step-by-step guide to go through. So it'd be great if, yeah, yeah, we'll share the link in the WhatsApp. And if the field epis can have a refresher on Excel and can start extracting information from the case investigation form into Excel, creating a line list, and then start thinking about a sit rep. And then when we come, we'll help you with any problems that you have.
Do you want Barry to do closing remarks now, Joe? Joe, are you with us?
Oh, yes, I only wanted to show the manual as well. We're giving you lots of homework, but when James and Barry come to visit, we're hoping you can also get a start on completing the manual for Oro Province.
Yeah, that'd be great, actually, if we could have it signed off when we're there. Manual completed and signed off by whoever.
And then what we might do now is we'll get Barry to do some closing remarks, and then we'll have a group photo of everybody before you go, so we can get a team shot of everybody in all the different locations. And then if you don't mind spending a little bit of time just doing day 2's evaluation for us so that we can improve this training for the next province that we go to.
What time are we in now? We are at 5 o'clock.
Barry, over to you.
Okay, I want to make it short, my closing remarks. I spoke a lot yesterday and today, but I just want to say thank you for Oro for coming on board, because it has been worrying to me as well as members of the NCC, and we know your problems and issues. And I think the 2 days training at least could help you or will help you to kickstart some working together. I think the most important, the end result of our 2 days training will be, I want to see, you may not do perfect in areas that we anticipate, but I think you as a team working together will be the first start. And meeting maybe once in a week, or now that we're in a pandemic phase, maybe more frequent, maybe twice a week or 3 times a week, for 1 hour session, something like that, just to update each other. And that kind of, I think meeting together does help for you to know where you are at, so that the surveillance team or Gibson can give update of the results, and the person who's handling the RRT kit can give, what the usage. And so I think that's something that I would like to see, that the regular get-togethers happening. For now, let's forget about the administration. I know that already. The world knows about already, but we can't make change. We're not in charge of that. I think the team that you are there now is a team that you have your duties and responsibilities in your own areas during peacetime. But in this COVID, I think we all, working for the same goal, is to interrupt the transmission, and we can go back to our normal lives and deal with the normal day, kind of disease and things that we see. So I want to thank you all for participating in these 2 days. I think, and also I thank our team, Joanne. I think you are a master leader. Without you, I think we would not get through this. So, and James and Tambri is here with us, but you've been down there, and modern technology brings us together for all of us to be on the same platform and help Oro to have the RRT function. But we are looking forward to come down there next couple of weeks time, after we do Bougainville, West New Britain, Gulf, Western Islands. It gives us enough time, and you as well, so that we can come and see some results. As I said, not necessarily in the technical areas of what we may be thinking, what labs should do and what surveillance should do, but at least a team working together and having discussed, and maybe start putting some situation report to share with your administration and with us. So all I can say is thank you for participating, and we look forward to working with you. And I'm always available. Give me a call anytime, Gibson, and share my number with the rest of the team members. I am a link with the NCC, even though I'm not full-time in NCC. I have linked to everybody in NCC, and I have linked to the secretary and the minister. But I don't check people, I help people. So if you can provide me, if you can ask me the right questions, I can link you up with people to get help. Let's start today to see that you are working together and communicate together and work as a team, as technical team. We are not administrators. We are not. We don't make decisions on money. We don't make decisions on who comes on board. But as a technical team, let's work as a technical team to work together, communicate together, and let's see from there. I think your case numbers, I haven't seen the latest, but it's still not as we expect. Maybe because we're not collecting enough samples. But we also need to work on the front of getting more samples and getting more tested. With that, thank you. It's 5 o'clock, so thanks for me, everybody, and thanks for the team here as well, for everybody who's in this room, in James Flint room. We're using one room here, and also for those others online helping Team Oro on this training. And thank you, Laura, and also Joanne, for the 2 good days.
No problem at all. It's been a wonderful experience, and I've only put my camera on so we don't forget the photo. We would love to have the photo.
I will. Most of our participants have gone out. We'll at least get some of the participants who are here. Will put them on the photo and send over.
Dr. Gilbert and Alois, can you put your camera on? Great.
Come here.
Come.
Team, come and stand here.
Come here.
Move this up a bit so I can see everyone. That's it.
Okay, can I have all my participants? We don't have watch. I think we will all have to cut ourselves behind that.
Hard to fit everybody.
Yeah. Just I'm not maybe looking by a it seems loud.
Oh, that's great.
Oh, that's pretty good. Emmanuel, can you? No, William, can you move in a bit? Yeah, perfect. This is great.
Emmanuel is too tall. We need to cut some part of his head.
Let's get Oro to say something so the picture comes up biggest.
Wow, nice photo of me.
I can pin them, Joe. Pin Oro.
Can you pin Oro?
There we go.
Something?
Okay, Gibson, over to you.
Switch yourself.
There we go.
Sorry, I'm taking lots of screenshots. I just hope it works.
Oh, perfect.
Let me check this.
Sorry, John. Tell everybody to wear the mask because that's part of the.
Yeah, I thought you said take them off.
Okay, yeah, everyone mask again. Perfect. Okay.
Just wait, Charlie, I'm gonna get mask.
Barry hasn't got his mask on.
I'm gonna take one like this with the Oro team big, and then I'll make it 6 so it's all equal. Okay. Where's Bernie?
She's getting a mask.
Wait.
Oh, okay. I'll wait.
We have to wear mask.
IPCs.
There we go. Okay, ready?
No.
Oh, no.
Because if this goes out to the public and also the controller and the big bosses, I think that would not be good. So we need to know.
Somebody disappeared from there. Unless it's missing.
I have my mask too. I can.
Are you okay?
Really, I don't really need.
You don't need
Okay,
to.
Alois has his. Okay, let me know.
Okay, I'm ready.
Great. Okay. 1, 2, 3. Bear with me. I want to take 3 photos. So, and I just got to paste them into here. Okay, I'm going to make Stanley bigger now. Huh.
Do you want us to talk? Would that make it easier?
Yeah, no, this is good. Okay, 1, 2, 3. Okay. And now I'll make all equals. Okay. Last one. 1, 2, 3. Great. I hope the quality is good. Screenshotting into Word. But
for us, Joe.
Put on
I'll
the
send these
WhatsApp.
on. Yeah, yeah, I'll put them on WhatsApp. Thanks very much, everyone.
Thank you.
Thanks, Oro. We'll see you soon.
Don't forget the
Otherwise,
evaluation.
thank you.
Yeah, evaluation.
Yes, please, we need the feedback.
Okay, John, the evaluation forms, how do I send them to you?
Okay, thanks very much.
That will be
List as well. Gibson.
I scan them and email them to you. Or
Yeah,
you want the originals?
I don't need the original, so if you can scan and email, that works perfectly.
Okay, I'll do that.
Thank you so much.
Sounds good. You guys have a great night.
Okay, well, team from us here, we want to take this time and say thank you so much to the team out there, John, James, Chief Berry, and Laura, and James, and the team out there who have been so helpful to us over the last 2 days. It's been the first of its kind, we were left behind and in trying to catch up with the other provinces, but we said thank you for the time that you spent for us, and at least you give us something important that we have to work on. So many things happening, and we are a bit stagnant at the moment, but we will pick up with the assistance that you continue to provide, and we'll do what we are supposed to be doing. So let me say thank you all very much for your time. And we really appreciate your time you spent with us over the last 2 days. Thank you all.
Thank you, Gibson, and thank you everyone in Oro.
Yeah, it was our pleasure. Thank you very much.
Thank you.
Thank you.
We'll
Lovely to meet you all.
We'll see you all again. Some of you in person probably in a couple of weeks' time, I guess.
You'll see James and Barry soon. You'll see me when I come to do Kokoda Trail.
Good one.
After COVID.
Bye, everybody.
Bye.
Hi, James.
See you, Alois. See you next week, Alois. Hopefully.
Thanks, Alois.
Okay. Thank you, Gibson, for coordinating this very well. And thank you, John. Yeah, it's a very wonderful training. We enjoyed it.
Yes, thank you,
Yes,
Brother
great.
Alois.
Thanks, Alois.
Yeah.
Okay.
Bye,
Bye-bye.
everyone.
Really appreciate your input, Alois. Thank you.
Bye.
Bye, Laura. Thank you.
Okay. Lupit lah. Oleh itu ya, make sini play.